Let's get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers. This is one of those cases where you probably notice sometimes you get waves of things. Lately, I've had a wave of palliative care patients, so I thought I'd throw this one in here as well. What anticipatory orders are appropriate for managing evident symptoms in palliative care? Write 3 specific medications, route and rationale. Doses are not required. The main medications we tend to use in palliative care is subcutaneous morphine for pain, subcutaneous midazolam for agitation, subcutaneous metoclopramide for nausea. You can use oral ondansetron as well, or IM ondansetron. In this kind of setting, or there are wafers as well, but in this kind of setting where she's not really eating much, most people I think would probably stick to metoclopramide. And you can do, as required, subcutaneous glycopyrrolate or hyoscine for respiratory secretions should things progress. I'm really not a fan of glycopyrrolate or hyoscine for secretions, but I'll go on a rant for another day. We have from the chat here, change Targin to subcut morphine, and I think that the specifying ceasing Targin would actually count for a mark here as well. So definitely would get marks from there. Changing to morphine, 60 milligrams per day via Nicky pump. So I think certainly that's probably an appropriate dose for someone who's already on an equivalent of 40 of Targin over 24 hours. I don't think you'd risk narking them on that one. That's a dose I think I would be pretty happy with prescribing as well. As needed on Dan's sublingual, yes, you could try it. I think though, because they've specified that there are some troubles with oral intake, I'd probably prefer a subcutaneous route. I think you would probably get 1 mark for that still though. As needed, olanzapine, 2.5 milligrams subcut. Olanzapine actually tends to be a little bit less commonly used. Midazolam is usually favoured by most areas, and to be perfectly honest, not entirely sure why. I think olanzapine can be used, and I think you would still get some marks for that as well. Now I'm going to mention a couple of things here, and I said I wasn't going to go on a rant today, but bugger it, I will. So the subcut 4-hourly. This often comes back to your experience, the nurses who are involved experience, the setting of the venue. For a lot of my palliative patients, I actually don't put time locks on it. So it's essentially titrate to effect and to the patient's conscious state and level of sedation. And that just gives them that flexibility that if they've given a dose of something and the patient's still in a lot of pain, they're not forced to wait that 1 hour or 4 hours or whatever time is specified. They can just give that extra dose. And particularly when you're starting these orders, that can be really, really helpful to work out if you're just using initially PRNs or as required orders. It lets you work out then, well, where do I start that Nicky pump? And so for here where we're kind of starting medications, often I would actually leave the Target in place, start these subcut orders, and after 24 hours, go back and actually work out what were their requirements for that period, and I would use that to then start the pump to work it out. In this case specifically, though, where they've said she's not really tolerating oral intake, that's where I think Demia's suggestion of starting the Nicky pump now is actually pretty sensible. And so I think specifying that as well, yeah, you get the marks. As for the glycopyrrolate and hyoscine, I'm getting up on my box. It's a horrible medication, or a horrible class medication for palliative patients. For those who've heard the death rattle, the secretions in the back of the throat, it's something that can be quite distressing for family, for care providers, but not for the patient. The patient's deeply unconscious, and the whole reason why they're getting those is that they're no longer swallowing, they're no longer clearing those secretions, and so as they're breathing, you get that little gurgle there. I tell friends and family and care providers, that's great. It sounds really yucky, doesn't it? But that's actually a really nice sound, because that tells me that we have that person very comfortable. They're so comfortable, they're so at peace that they're not bothering to even swallow as much as they would normally do. So I think that's a good sign we're on top of their pain. Yeah, we've got some medications we can use to try and dry it up that might make it sound nicer. If you've ever been out on the town, hypothetically, had a few too many drinks maybe, and have fallen asleep with your mouth open, you wake up, you've got that really dry mouth, that dry as a bone mouth. It's a pretty unpleasant sensation. And that's what we induce in these patients to try and control that sound, control those secretions. And so in some regards, we're actually making the patient more uncomfortable to make ourselves not have to listen to it. And sometimes just that explanation, that bit of discussion around it is enough to make people a bit more comfortable and happy to maybe hold off on using those kinds of medications. Not always though. And so it can be handy to have them there, but often just that bit of a discussion around, look, if we're really focusing on their comfort, that's probably not something we need to be as worried about. It's that education around why that gurgle is there. Okay, I'll get off my box now. And we have a comment in from chat here. Some nurses get the shits if I don't put in strict time guidelines. Yes, some nurses do. They are incorrect. You do not have to specify timelines. And if they do, I actually write no time lock. That kind of puts the comfort into them, because what they're worried about is if you don't specify something and they're seen to be giving it too frequently, they wonder, well, am I liable if something goes wrong? Whereas I can say, well, no, I've taken that liability myself. I've specified no time lock. You're in the clear. You don't have to worry medico-legally. I will wear that. And that's why I mentioned as well that you do have to kind of judge with the patient, with the facility, with the staff, kind of their level of comfort as well, their level of experience. Are they likely to do something silly, in which case I might be more inclined to specify some locks there. But for the teams I've worked with for a long time now, for years now, I'm very happy to say, as required, no time locks, and we can titrate to effect a bit more rapidly, a bit more readily, and get that patient more comfortable sooner. There we go. That was a good little chat there. Of course, this is 2.1. We've got more questions in here, so let's have a look. Let's get another 2 minutes on the clock, and your time starts now. All right, time is up, and let's have a look at some answers here. So hopefully not a situation you find yourself in, but these kinds of things do happen, unfortunately, falls in particular, and you'll sometimes find that one of the answers for these questions is hidden into the stem as well. So sure enough, if we look at this list here, we do have death occurring within 24 hours of a fall in an aged care facility. The first thing I'll point out with these is that each state and territory has its own little laws, but there are some commonalities between them all, which is what's been used to put this question here together. So of course the number one thing is going to be a death resulting from an accident or injury, so an unexpected death. A death occurring in unexpected or suspicious circumstances. If we can't explain it, if something feels a bit off, going to need to go to the coroner. And of course, death where medical care or treatment may have contributed to the outcome. You'll sometimes hear in some states there might be kind of time locks on there as to when that's considered to be the case, whereas other states will have rules which is more regardless of when that operation or procedure occurred, if it actually contributed to the death, it still becomes a reportable death. Coming in from the chat is pregnancy. So yes, in some states and territories, all pregnancies are considered to be reportable. Recent fall, again, the time frame will change depending on where you are. Recent general anaesthetic, again, depending on procedure. And cause of death suspicious, so all fantastic responses in there. Good. So in this case, I hate to say, but yes, this would be a reportable death to the coroner and would need to be discussed with them. And for places like Mildura, where I am, we're 6.5, 7 hours drive to Melbourne. So often they fly bodies down, and more often than not, they just get a CT scan and are sent back after 24 hours. So it's a lot of legwork. We appreciate it doesn't tend to change management of patients so much, but it's a way of trying to track, say, facilities. If there's a sudden run of falls occurring or suspicious deaths, are there things we can actually use to try and improve the situation and prevent these from occurring again? So a pretty important one to try and track and trace. All right, we have a third part of this question, so let's get 2 minutes on the clock again, and your time starts now. All right, time is up. Let's have a look at some answers here. So the clinical criteria are going to be no palpable carotid pulse, no heart sounds heard for 2 minutes, no breath sounds heard for 2 minutes, fixed, non-responsive and dilated pupils, no response to centralized stimulus. And some examples of that would be trapezius muscle squeeze, supraorbital pressure, mandibular pressure, or the sternal rub, although do be mindful if you're doing a sternal rub, just make sure you don't cause any skin tears, particularly if they're old and frail. No motor response or facial grimace to painful stimulus. I would be a bit nervous using an or there. I'd just stick to no motor response to painful stimulus or no facial grimace to painful stimulus. And that's, again, response like pinching the inner aspect of the elbow or ear, just something to cause a bit of pain there. And interestingly, one that catches a lot of people out is ECG strip shows no rhythm is actually not worth any marks. It's considered an optional part of the assessment, but isn't one of the ones that's required for verification of death. Coming in from the chat, we've got the absent papillary light response, fantastic. No response to sternal rub, no breathing sounds for 10 seconds, 2 minutes. So a bit longer there, absent quarter pulse for 10 seconds, 2 minutes, no response to voice. So that would be, you would, I guess, class that as a centralized stimulus, I guess, if you're right up in their face, maybe. But yes, so legally, we should actually be doing that auscultation for a full 2 minutes. And I can tell you, it's a long 2 minutes, particularly if the family are there and watching you do it all, and you feel a bit stupid because everyone can see that the person has passed away. But them's the rules. Now, there have been some unfortunate and embarrassing cases where people have been declared dead and they're not. And so I think it is important to actually do it for a good length of time to just make sure you're not going to find yourself in one of those situations. Now, I will admit that there have been times where I might be, say, in a funeral parlour where I'm happier to perhaps be a bit more brief with the verification because tends to be a little bit more obvious. But again, if we're doing things to the letter of law and if we're asked in an exam, and yes, this is fair game, these are the things you need to be popping in there. Again, as an aside, I'm doing a few of these tonight. The verification of death is not a consultation that you can actually build through to Medicare, and this is a point of contention for some people. But I kind of see it as my final service to that patient, looking after them in their medical needs. It's that final chance to wish them well on whatever journey they're on next if you're into any of those kinds of things. But I think it's a nice way to kind of tie up that patient-GP relationship, and you do it for the love of the job, really. You don't get paid for it, but that's the way it goes.